All right. I think we're just about ready to get started. So welcome everyone to our weekly orthopedic surgery grand rounds. Today we have a very special visiting speaker. And for introduction, we'll turn it over to Dr. Hansen.
Good morning, everyone. Gives me a distinct pleasure to introduce our visiting professor this morning. Dr. Jeremy Gilliland comes to us via the University of Utah, where he serves as associate professor, chief of orthopedics at the VA, and their director of clinical research. I don't think it's an exaggeration to say that he's one of the rising stars in our subspecialty for his contributions in education, research, and leadership. Regarding education, locally, he's been nominated by his trainees as the best teacher in multiple years. Nationally, he's a known entity at many of our CME meetings, and he's internationally recognized and been visiting professors recently in Spain and in Argentina. From a research perspective, like many of our visiting professors, he's got triple-digit publications, numerous named research awards. His interests are in complications after arthroplasty, as well as the thoughtful adoption of technology into the OR. And finally, in terms of leadership, he's probably one of the youngest inductees into the prestigious Hip and Knee Society. He's served on multiple committees with the American Association of Hip and Knee Surgeons and was the program chair of our annual meeting a couple of years ago. And it's my pleasure to introduce him to the podium and share his thoughts on a topic that's near and dear to many of our hearts.
Okay. Well, thanks. Those words are too kind. It's a real honor to be here. Obviously, we had dinner last night, and it's just so fun to hang out with your group. I find that your faculty really sort of mirrors ours, and sort of feel like we have a similar kind of small homegrown program with a lot of inbreeding within our own group, and it's been fun to make friendships with all your faculty over the years. So we're going to talk about pus and really kind of what I feel like is something that we know very, very little about. Unfortunately, I wish we knew more about this field. And I think at the end of this, you're going to go, I didn't learn a thing. And I really still know nothing about this topic. I don't know if this thing actually works. Let's see. Maybe I'll sit up here. So a bit about me. I did come to you guys from Utah, but in the past I was an engineer. So I studied mechanical engineering at Cal Poly San Luis Obispo, and I worked in a few different fields. I designed municipal water tanks, bicycles, and concrete highway paving machinery. And eventually I got tired of staring at a CAD machine and decided to go back to med school, and I went to UC Irvine. So I did spend some time in California, but after spending 4 years in Orange County, I realized I can't afford this place and it's way too crowded. So we left and went to Utah. But I do have a family. More importantly, I've got 3 daughters, 18, 16, and 8, and they definitely keep life interesting. We did head from California to Utah, and I'd never been to Utah. I knew nothing about the state, and I haven't left since. And so, for those that are geographically not so inclined, that's where Utah is, and that's where I am now. This is where I live in Utah, in Salt Lake City. It's a pretty fun place to live. It's like living in the Swiss Alps, and it's an interesting place to practice, more importantly, because we're in the middle of nowhere, surrounded by a lot of nowhere. And really, we're one of the only tertiary care academic medical centers for about a population of about 25 million people in about 5 states. And most all of that stuff ships to us. And so it leads to a pretty fun practice and not having to be in a huge city that keeps us real busy and gives us opportunities to do fun things. My family, we like to canyoneer. This was actually just 2 days ago down in southern Utah with my 2 daughters doing that. I like to ski. I like to mountain bike, and it provides all those opportunities for me. I do miss surfing, so I do like to surf. It's one of my passions, and so unfortunately I have to travel to do that because there's not a lot of ocean around us, but it leads to some fun travel time. We've got a good group. We've got 6 residents a year. I have 3 fellows a year, and I've got 5 great arthroplasty partners. And so it's a fun place to work. This is our fellow annual bike ride where we take the old fellows and new fellows and and get them together and do a mountain bike ride and try not to kill them. And it's a real fun time. So it really leads to a pretty fun place to practice and train residents and fellows. My practice is a mix of anterior hip replacement. So I do believe in the anterior hip replacement and that surgery. And I've done a lot of research in that space and developing some technology in that space. And then I do a fair bit of revision and pus work, as many of us have been talking about. And I also have a separate little side gig where I do some research and work in the percutaneous osseointegration space. And so another kind of passion of mine. So we're here to talk about pus, and I think it's arguably the number one problem in arthroplasty these days. And it's something that all of us really, regardless of how much you like it, becomes near and dear to your heart. Dan Barry, one of my close kind of friends and mentors in this process, really gave a great talk at CCGR, and he's given it a couple other places about this being really the biggest problem in total joint arthroplasty and probably the biggest unsolved problem we have. If you look at the American Joint Registry here, the number one reason for revision for both hip and knee replacement is infection. This isn't just in our country. This is the Australian registry. In the first 10 years, number one reason for revision of both hip and knee replacement is infection. And so it is the problem that we are all having to face. And if you look at how we're doing, this is the Australian registry. If you look at these periods of time, 4-year increments, the red line is can you guys hear okay? Yeah, I could just kill this one. Just take this stock. So if you look at how we're doing with this problem, that red line and then the yellow line for shoulders down there, because obviously shoulders are lagging a bit behind in terms of just some time on the scene. You can see that this is the percent revisions for infection. It's not numbers, but percentage of all surgeries being done. And you can see we're not doing better. We're if anything doing worse. There's more and more revisions as a percentage of our revisions coming online because of infection. The same thing is echoed in the American registry, where you can see that the percentage of revisions over time is going up for infection, not going down and not leveling off. And so certainly it's not something that I think we have mastered in any way, shape, or form. This is revisions in the Australian registry for aseptic and septic regions. You can see we're getting better at avoiding septic or aseptic failures with that blue line. But if you look at the red line, the septic revisions, it's plateaued, if anything, going slowly up over time. So over this 20-year period, we had really no impact on decreasing rates of infection. And this is despite all these things that we're throwing at it, staff screening, optimizing our patients, smoking cessation, antibiotic protocols, voodoos and potions that we throw in the wound, and we're hoping to sort of make a difference. And this is a slide from Dr. Barry, and really kind of feels like most of this is just fooling around. And I would echo that. I think that we're fooling around, and I don't know that we're really making big gains. And if you look at how we're doing at treating these problems, go 10 years down the road with all of these treatments for infection in the Australian registry, nearly 30% failure rate, right? So a third of our patients aren't getting successful outcomes. And so it's really something that's kind of dismal if you think about it. This is Insol's paper, the first really description of a 2-stage revision in 1983, so over 40 years ago. And he had 11 patients, so albeit a small cohort, but 91% success at 34 months. I mean, that's a win. That's like better than anything published nowadays. That was 40 years ago. So I don't think we've made really any headways in terms of getting better at how we treat these patients. And why is that? Well, I think it's because we're dealing with an enemy that's really something that we don't fully understand. This is some work from one of my colleagues, Dustin Williams, who's a biofilm researcher that I work with. This is a scanning electron microscopy of a biofilm. And if you look at that, it sort of just horrifies you. I mean, these things, the bacteria attach to implants, they secrete these matrices, they mature, and they can shed free planktonic bacteria whenever they want. And antibiotics really can only kill the free planktonic bacteria. This happens within minutes. So bacteria will attach, they form these microcolonies in a couple of hours. They secrete a matrix of proteoglycans and a protective matrix within a few hours. And then they evolve into these mature biofilms over a couple of days. And they can rapidly recover from mechanical disruption as well as share antibiotic-resistant genes amongst themselves if they're getting some insult from antibiotics. And they can lie dormant, more importantly, for months to years. And so I think we get these patients where we feel like we've won, we've treated infection, they're doing well, and then 2 years later they come back and boom, it's back. And that's because these biofilms can just hang out and then release some planktonic bacteria whenever there's some host weakness. And so it's something that I think it's really, really challenging for us to figure out how to treat these things when we're fighting an enemy like that. And if you look at how our patients are suffering from this complication, this is the Australian Registry, again, looking at mortality of these patients for these problems with all of these treatments. And you can see that after a decade, really 50% mortality. And you might say that, well, that's just because they're old and they get old and they die. But the reality is, if you look at Parvizi's paper here comparing septic to aseptic revisions, it's a 5-fold increase of mortality when you have a septic failure. And if you compare that to many of the common cancers, infection really beats most of the common cancers that our patients are dealing with. And so, it's like giving our patients a pretty untreatable cancer. And so I think this is a problem that we really, really need to be trying to avoid. And I think we need to somehow figure out how to do better at that. The cost is also just dismal. I mean, the projected cost in the U.S. by 2030 is $1.85 billion to treat PJI. That's with a B. That's really, really expensive. And every time we get a PJI, it's about 3-fold the cost of a primer. So with all that, you can probably just say, okay, why are we even talking about this? Because obviously we're really doing bad at this. And the rest of this stuff is going to be stuff that we're doing bad. And I don't have any great answers for you. I haven't solved this problem, but I'll just tell you some things that we've done, and hopefully it'll kind of lead to some of you younger folks thinking about the problem, hopefully going out into your practices and doing some research to solve some of these issues, because I think it's what we need to be thinking about. So in Utah, we have this population database. It's a unique resource that we have only in our state, where we've got genealogic data tied to medical records. And so we've been using that to kind of look at this problem and see if we can learn something about it. Interestingly, these are some of the published risk factors for infection, and why male sex is always there, nobody knows. And so just in and of itself, there's yet another thing that I think none of us really truly understand, why males are really have a almost 2-fold higher rate of infection than females. I saw this paper by Hani Bader presented about 12 years ago, and he had looked at patients who'd had a total joint that had been infected and then went on to have treatment and go on to get another total joint, found they were 21 times higher rate of infection in that second joint than someone who had not had infection. And this got me thinking about, is there some sort of a genetic link? Because that seems like quite a bit higher. It's not just that their other side got infected from the other side. These were successfully treated infections who then got reinfected in another joint. So it made me start thinking about the genetic link. And so we first went to the Utah population database to look at this very question: is there a genetic link? And we sort of looked for familial clustering within PJI patients. We looked at this database. We had about 66,000 joints over this time period, about 1,500 of which had been infected. Found the same kind of things. Males are higher rates of infection, obesity, smokers, diabetics, end-stage renal disease, all the things that we kind of already know. But then we looked at the overall group, and we had a rate of infection of about 2.3%. We looked at relatives of non-PJI patients, so patients whose relatives had a joint that didn't get infected, then went on to get a joint. They had the same rate of overall infection of about 2.3%, depending on their first, second-degree relatives and all that. But then we looked at relatives of PJI-positive patients, so patients whose relative had a joint, got infected, and then they went on to get a joint, and that first-degree relatives had double the rate of infection. So it certainly kind of sparked some interest on our part. We plotted this out in terms of infection-free survival, and you can see that the PJI-positive relatives were at a significantly increased risk of infection. And this allowed us to find these pedigrees within the system where we could then map out high-risk pedigrees based on the number of joints in their family and the number that got infected. This is a pedigree with an infection rate of 7-fold the incidence of the general population. So we have these pedigrees, and over the past 10 years, I've been trying to get access to these families. That has turned out to be a much more difficult thing than I thought. But we now have finally gotten in touch with one family and have gotten genetic data from several members of that family. And so we're in the process of trying to find, are there some target genes that we can sort of look at and understand? Using that same database, we started to ask the questions about socioeconomic status. And CDC defines socioeconomic status as social status measured by education, income, for economic status, and occupation for work status. And none of these are really defined relationships with periprosthetic joint infections. So we went to that, first looked at education, found really no associated risk of PJI. Income, we didn't find any associated risk of PJI. But on payer status, Medicaid still popped up as a risk factor for PJI, and that's shown in many series. But for us, Medicaid status has always been thought of as a socioeconomic surrogate. And for us, we're kind of thinking that potentially Medicaid is a surrogate for other things like engagement in the patient's healthcare, less so than maybe socioeconomic status. And we then were able to control for these socioeconomic variables to make sure that our familial data was not just a socioeconomic thing, and found that our familial data still remained. And so gave us some hope that these pedigrees will hopefully lead to something in the way of genetic understanding. And then we looked at diabetes, looking at this population really to answer the question of, if you have this thin type 1 diabetic, is that patient at more risk than a sort of obese type 2 diabetic? For me, I thought, well, for sure that the obese type 2 diabetic is going to be higher risk. So we went to the database and tried to find this out. And interestingly, we found that our type 1 diabetics were at nearly a double increased risk of infection compared to our type 2 diabetics, which I think was a fairly novel thing that we found and has sparked some interest on our part. We looked at diabetic complications and found that all these diabetic complications were associated with PJI. And interestingly, as the number of complications go up for a given patient, their rate of PJI goes up dramatically. And so, it's really kind of made us start thinking about asking our patients about their diabetic complication histories, more so than just looking at things like A1C. Interestingly, as we look at those type 1 diabetics, if they're underweight and type 1 diabetic, their risk of infection is way, way higher than if you have the overweight type 2 diabetic. So while we tend to think of that overweight type 2 diabetic and think, that they're the ones that are going to be more risk for infection, the type 1 underweight diabetics, which are not that infrequent, are pretty high risk. And so, it just emphasized to us the need to better understand our patients' history of complications with diabetes, and that type 1 diabetics are ones to not be ignored. And so, the only take homes we have from this is that I think getting a family history of PJI. So I ask my patients that come in with infection, what's your family history? Do you have any other family members? And certainly primary patients, kind of get a story from them, not only ask about their history of infection with other surgeries, but anybody in your family have a high risk of infection, or have you had lots of family members that have infection, because certainly that makes you think about, them potentially having some sort of predisposition. And then I think understanding, diabetic complication history, and obviously our Medicaid patients, which we all know, can be at higher risk. So how do we prevent this problem? Well, I think, obviously prevention is worth a pound of cure, but obviously, as we talked about before, I don't know that there's really anything that we're doing that's really working. So I'm going to tell you about what we're doing, whether it's really making an impact. I can't honestly say. Modifiable risk factors are things we talk about a lot, but I think when we talk about modifiable risk factors, we have to be careful about understanding the difference between relative and absolute risk, right? And in obesity, for instance, we've gotten this terribly wrong, I think. And so we went through a phase where we said, anybody over BMI of 40, we should not do joint replacement on. And the reality is we were doing that based on a relative risk, not absolute risk. And so, the relative risk is quite a bit higher in obese patients, but the absolute risk is still really low. And so I still think that we need to be cautious about applying some of these rules to every patient, saying, hey, you shouldn't get surgery because you're at increased risk. But we should be managing our patients and trying to optimize them. Things like anemia, we shouldn't avoid. Hep C, it's treatable now, and that's something that I think we should be treating before we do arthroplasty. And then, something I think has come on the scene over the last 5 or 10 years that's become, kind of commonplace is if you've had an injection, we need to wait at least 3 months before we do surgery. And these are simple things that I think we can do to avoid infection in some of our patients. In our inflammatory arthropathy patients, this was always something where it was kind of unknown territory. What do we do with all these crazy medicines that they're on? And we'd send them to the rheumatologist and they'd say, I don't know what to do with it. And so, this is a project that I was involved with the American College of Rheumatology and ACUS combined efforts, where we came up with these guidelines to talk about what we do with these medications that the inflammatory arthropathy patients are on. And really it boils down, if they're on DMARD, you can continue them. If they're on biologics, you should hold them for a dosing cycle. And if they're lupus patients, really gets down to how severe their symptoms are. We tried to study this after we put that guideline out to see, does it really work? And so I looked at the VA database, and found a population of inflammatory arthritis patients that were on biologics before their primary, looked at 29 of them who had developed PJI, and then compared to a matched cohort who didn't. And interestingly found that those that had continued biologics did have an odds ratio of about 3.5 of developing infection. So I think these guidelines do make sense. And we've since published a newer series on this, just looking at some of the newer biologics and JAK inhibitors. And so this is kind of one to have in the back pocket. If you don't have it, it's really helpful. And I think does kind of hopefully limit some of the infection in these patients on immunosuppressives. What about antibiotics? Preoperatively, we hear this all the time from our anesthesiologists. So we can't give Ancef because they have a penicillin allergy. I think that just needs to be debunked, and you need to tell your anesthesiologist that that's BS, right? And the reality is that about 10% of patients who have a penicillin allergy really have an allergy, and there's less than 3% cross-reactivity between penicillin and cephalosporins. And there's a recent series out of New York where they looked at this very question, and in anaphylactic penicillin allergy patients, so patients that had a real penicillin allergy, there's only about a 0.1% chance that they would have some sort of reaction to cephalosporins. And so I think it's really important that our patients are getting a cephalosporin almost always, and that we don't use alternative antibiotics. And this was shown by Cody Wiles in a Mayo group where they found a 32% lower risk of PJI with Ancef compared to alternatives. And so it's really something to talk to our anesthesiology colleagues about, like, please give Ancef, do not avoid it. And if the patient has a history of a penicillin allergy, I think you can just proceed forward. And if they have a reaction, give them Benadryl or intubate in the OR if worst case scenario, but that just doesn't happen if you look at the literature. I think it's common for underdosing to occur, and we need to be giving weight-based dosing, something also to be talking to your anesthesiology colleague about, making sure they're weight-based dosing. And then if they're using Vanco, weight-based dose it, and try not to use Vanco in isolation. It's not a good preoperative antibiotic to be using by itself. How long do we do antibiotics? This is definitely something that's being talked about a bunch in our field. I think right now the CDC says 1 dose, and I think that's what the data would support. There's a multi-center trial going on with ACUS to look at this very question, like, do you need to give a second dose? I'll tell you, in my practice, about 90% of my patients go home the same day from primary arthroplasty, and they just get 1 dose. We don't send with any more antibiotics. They don't get a second dose in the PACU, and they don't get a second dose in their same day surgery, and they just go home after the 1 dose preoperatively. And I think this is going to be kind of standard in our field. And there's also discussion about these prolonged oral courses of antibiotics for high risk patients. I don't think any of the data is really founded in that space, and many of the studies that have looked at that after the first study published on that have really not corroborated the data that really is helpful. Well, what can we do in the OR? I think reducing the operative time is something that we all talk about, and I think it's valid. We need to decrease operative times, but that doesn't need to come at the case of really kind of mishandling the soft tissues. And I think that soft tissue handling is probably the most important thing we can do in the OR to prevent infection. But it's unfortunately the thing that we can't study. You can't study how well was the soft tissue handled. But if you blaze through a case and get it done in 15 minutes and you leave the soft tissue like this, it doesn't matter how quick you did the case. And I think you need to be cautious about treating the soft tissue with care. Reducing OR traffic, I think, is really, really important. People are the greatest source of contamination in the OR, no question. Many people shed up to 10,000 bacteria per minute. So if you are shedding that much bacteria and you have a whole clan of people in the OR, good luck preventing that bacteria from getting on the back table or getting into your field. So preventing OR traffic is really key. At our place, we do this. We tape a big X on the door, hang up signs to say, please don't come in this door. We're doing a total joint. And it really kind of diverts traffic through the core and tries to keep people out of our rooms. Sir John Charlie was really kind of one of the first people that really started to innovate in the infection space. His infection rate when he started doing total hip arthroplasty was 50%. And I would have jumped off a bridge at that point. And it really took a lot of tenacity to keep going, but he kept proceeding forward, developed things like the body exhaust suit, laminar flow, using antibiotics routinely before surgery. All these things were not routine, and it brought his infection rate down less than 10%, and actually into the realm of about 2% by the time he finished practice, so similar to what we have nowadays. But these suits evolved to our modern spacesuits, and our modern spacesuits are not body exhaust suits. They're air conditioning devices for ourselves, and they're positive pressure. right? And so if you look at the data, this is a systematic review comparing the body exhaust suit data to the modern positive pressure surgical helmet systems. The body exhaust suits prevented infection. And if you look at the data here, our modern spacesuits probably cause infection. So while they are helpful in air conditioning devices for ourselves, and they certainly keep all the pus and spray off of our faces, they aren't necessarily helpful to our patients. And so there's been a couple of studies looking at this. Why is this the case? Well, it's because of their positive pressure. This is a study by Mark Spengel. They looked at the glove-gown interface using this fluorescent dye and found that, a lot of particle debris was coming out of our glove-gown interface. Matt Dietz out of West Virginia looked at this and said, if you power up your hood before you put your gown on, it's just blowing all the stuff off the top of your head, all over your scrub tech and all over the back table before you put your gown on. So don't power it up until you're all gowned up. And then finally, if you're using these standard gowns with a rear tide closure, you're just powering all that air out your back, all over your scrub tech and all over the back table. So we should be wearing sort of vests. And if you wear these vests, you can see a dramatic reduction in the contamination rate just by putting a vest on that covers your back or using a toga type gown. And so what do? We tape our glove gown interface. So we use Coban because we still wear hoods. I think they're nice. They protect us. But we tape our interface. Then after we've taped up our gown and we're all gowned up, then we power up the unit, and that's become a standard. We put these signs up to show the nurses that please don't have it powered up. And then we wear these cute, what I call smoking jackets. They're vests that cover up our backs. And I think it's a way to potentially still use these devices, but hopefully not be causing trouble. What about skin preps? There's a lot of discussion about this in multiple fields in orthopedics. And typically the chlorhexidine has been shown to be better than povidone iodine, but what's been missed is a lot of times that's chlorhexidine alcohol compared to povidone iodine without alcohol. And so really the alcohol component is probably the most important part, and it's probably not the other stuff that's in there. And the CDC would recommend that we need to be using an alcohol-based prep, and that's the most important thing. And interestingly, the prep trial in trauma right now just finished, and they're publishing their data now, and they're actually showing that DuraPrep was better than ChloroPrep because both are alcohol-based preps. And so I think it's the most important thing is that you use an alcohol-based prep, make sure that what you're using has alcohol in it, and that's probably all that really matters. Irrigations, there's a whole slew of them out there. A lot of proprietary ones, the things that, they select this PHMB one I was looking at recently, and they swear it's, better than anything on the market. But ultimately, there's not a lot of data on much of any of them except for dilute betadine. It comes to like what you put in your irrigant. This is an old trauma surgery study, the FLOWS trial. Basically found that just saline is probably better than anything. And then this is the one study that in our field really kind of took hold back in 2012 out of Rush, where they looked at that dilute betadine and found that dilute betadine lavage really decreased their infection rates. And this has been corroborated in several other studies. And I think now the CDC, if you look at the 2017 guidelines, actually says that we should be using dilute betadine. We use it. Don't know that it's an absolute game changer as much as people say, but I think it's certainly something that I don't think is harmful and is being used fairly routinely. Topical antibiotics, what we call a magic pixie dust or fairy dust, I think really the spine literature appeared really promising when this came on the field about 10 years ago. The arthroplasty literature currently, I don't think supports its use. I don't think that there are enough studies to say that this actually is helpful, and the CDC recommends against it with the concern for developing, multi-drug resistance. And so I personally don't think that there's enough data here to be doing this routinely. And there's actually a recent study in arthroplasty that was just published. It's kind of preprint right now, showing actually worsened infection rates in primary joints with the use of Vanco powder compared to nothing. And that may be because of some local soft tissue toxicity and wound healing problems because of the Vanco powder. And so it's certainly something that I don't think we have a great answer to. This is something that we looked at the end of a couple cases. I looked back at the back table, and the splash basin looked like what I called a cesspool. And, I was wondering, like, why the heck am I soaking all my instruments in that pool of garbage? And so we decided to randomize our cesspools to either dilute chlorhexidine in the fluid, or just saline. And then we just randomized those and looked at culture growth after the cases. These are all primary joint cases. And we had 9% positive cultures in the sterile water group and nothing in the CHG group. And there was a trend toward higher wound complications in the group that had no CHG in the fluid. And so this has become a standard at our shop that we just put dilute chlorhexidine in the splash basins. You could certainly say just don't use the splash basins, and I think that's fine as well. But if you're using them, I think prophylaxing that in some way does make some sense to me. So, I think these intraoperative techniques for us, we don't use any laminar flow. I think the laminar flow has been debunked and there's not much data for its use. We do use hoods still, but we treat them as non-sterile. So we try not to touch them. We tape the interfaces. We plug in our batteries afterwards and we wear these vests. And then for skin prep, we use alcohol-based preps, whether that be DuraPrep or ChloroPrep. I don't think you can really hang your hat on one or another. I do think that if you're using Ioban, which the data would not necessarily support is a must, you should be using sort of a DuraPrep type solution because it keeps the Ioban down, and it's the peel up of Ioban that actually becomes an issue. And for us, we irrigate with just saline. We do use dilute betadine. I think it's a consideration, and we put that dilute CHG in our splash version. So when it comes to treatment of this problem, look, how do we treat this? Well, I think you have two options. You can keep the parts and pray, or we can take the parts out and either do it in a 1-stage or a 2-stage process. And I think that there's still quite a lot of debate in that space. When it comes to debridement and implant retention or DAIR, I think you have to know the bug. And if you have a resistant bug like MRSA, the failure rates are just disastrously high. And I think there's really limited indication in those patients. But if you don't have a resistant bug, like how do you make this work? Well, these are all the common questions, and I'll sort of go through. I gave a talk on this, and so I kind of pulled some of those slides. This was out of the ICM guidelines back in 2019. And so we kind of just addressed each of these issues. What's the ideal perioperative antibiotic regimen? I think if you're using or doing a DAIR and it's in a staph bug, you should be using rifampin. Rifampin is important to add for biofilm and any implant retention. And fluoroquinolones, surprisingly, oral fluoroquinolones are probably better than anything. And the same in gram-negative infections, we should be using fluoroquinolones more. So something to talk to your ID docs about, like, can we use an oral fluoroquinolone agent? Because I think the data would support that use. Duration of antibiotic therapy, I think 6 to 12 weeks is probably all you need. And I don't think anything beyond that is really supported by literature. And chronic suppression, while we like to think it's going to do something, I think it's just delaying the inevitable. And so in those patients where it's going to come back, it's just delayed until they stop. And I have never met a patient yet who's on antibiotics for life. Most patients after a year or two stop because their primary care doc stops them, or they get sick by them, or whatever. It's not a very well tolerated thing for life. And so I think rarely do patients actually stay on it. What about resorbable antibiotic beads? I think there's limited high quality evidence here, and actually some added complications of drainage and hypercalcemia. And most of these things have really kind of fallen away from popularity in our field. And then powdered antibiotics, as we talked about before, I think there's really limited high-quality evidence and limited complications reported, but certainly now some stuff popping up about the fact that this may be actually causing harm rather than just good in our patients. So what about revision, and what do we do? Should we be doing 1 stages or 2 stages? Well, I think that there's a lot of debate in this space right now. It's an interesting time for us. This is one of my friends, Faris Haddad from London. He's done a lot of work in the 1-stage group, and they've looked at their experience and have found that their single-stage patients actually do better. They've seen a evolution of practice in the UK, where a trend toward more 1-stage utilization, but the 2-stage regime does still dominate there as well. And in systematic reviews, Faris states that there's really no suggestion in the literature that 1 stages or 2 stages have different outcomes. And a lot of people would say, well, that's because it's cherry-picked data, that the 1 stages are in patients who are healthier and have less resistant bugs, and that randomized trials are really needed to answer this question. Well, this was the first randomized trial, the INFORM trial out of UK and Sweden. This is all total hips, relatively small trial because it was powered on WOMAC score, not powered on outcomes of infection recurrence. And they found that in the first 3 months, not surprisingly, single-stage patients were doing better from an outcome standpoint, and they concluded that outcomes are better with single stage, fewer intraoperative complications, and it's a cost-effective thing, which are not surprising findings. I don't think really teach us much, but they didn't see really any difference in infection recurrence because it was really underpowered for that and quite a small study. So this brings in probably the best study in this space that's really underway. It's not quite done, by one of my mentors, Tom Faring, a multi-center prospective randomized trial in this same space. Two really great institutions were part of this full multi-center study, Utah and UCSF, and so I'd highlight that. But it's a multi-center study across the country where we really randomized infected patients to 1 versus 2 stage. And the inclusion criteria was quite open, meaning pretty much everybody could have this unless you'd had a prior revision or you were immunosuppressed. So it had to be a primary that was infected, and it really didn't matter what your host classification was. If it was a resistant bug, everybody was available to have this done. Everybody got the same thing, which was a clean and dirty setup. So basically 2 surgeries in 1. And it was really a protocol-driven study where everybody had the exact same protocol, same antibiotics, same irrigations, double setup, and then, a similar post-operative antibiotic regimen. And at 1 year, and I'll tell you, this is prelim data, it's not published yet, but at 1 year, interestingly, it looked like the 1-stage patients were trending toward actually doing better, although statistically not different. And if we controlled for comorbidity, surprisingly, the 1-stage treatment were statistically 4 times better off than the 2-stage people. If you looked at resistant bugs, the 1-stage people were, again, doing better by an odds ratio of about 4 times. And for draining sinus, again, the 1-stage patients, surprisingly, were trending toward doing better, not quite statistically significant, but very close to about, again, almost a 4-fold increased risk or increased success compared to the 2-stage, which is sort of opposite what we'd expect. And so we're hoping that this 2-year data, that's going to be our final endpoint, will be out. Should be out by the end of the year. And hopefully this will answer some questions for us. But right now, the interim results are looking pretty good for the 1-stage process compared to 2-stage, which is quite surprising because this is really all comers. And we were part of this study. I was talking to the guys last night. We did some people in this 1-stage that were really, really nasty infections, and I thought this was a really dumb idea. And honestly, they've all done quite well. So how do we do 2-stage revision? Because I still think this is the gold standard, and I think we've done a lot of work in this space at our place, and so I'll just kind of tell you some of the things that I do. I think when you talk about spacers, we need to be articulating all of our spacers. Historically, we do static spacers or non-articulating hip spacers, and I think we should be trying to articulate as many spacers as possible. It leads to a better soft tissue envelope and I think a better outcome for the patient. So for me, in knees, it's almost everybody gets an articulating spacer unless you have a huge soft tissue defect that can't be closed, big collateral ligament deficiency or extreme bone loss. And in hips, it's almost everybody unless you've got a giant hole that I can't fill. But even in pelvic discontinuities, I'll do spacers and just bridge them with screws. And I'll show you that in a bit. I think it's important to realize that when you're doing an infected case, that everything in the room is contaminated. This is studied by Matt Dietz out of Virginia, where they just cultured all the surfaces of septic and aseptic revisions and found that in septic revisions, almost all the surfaces in the OR, 93% of surfaces were positive for the bug that they were treating. And so you can't be debriding and taking everything out and then putting in your final parts with all the infected instruments and light handles and everything else in the room that's infected. We need to be sort of decontaminating those spaces and putting in, our parts with clean stuff. The double draping technique is something that we developed, though, because I think that it's very inefficient to strip down all the drapes and then try to re-prep and re-drape the patient. I think it's also somewhat dangerous, especially in the hip setting. If a patient's in the lateral decubitus and you've taken all the parts out and you're holding their leg up to try to re-prep, sometimes the trochanter is impinging on the pelvis, and we've seen some broken trochanters and broken femurs in that case. And so I think it's important to try to do this safely. And so for us, we developed this double draping technique where we drape and prep the patient twice at the beginning. And then we do the first surgery, the dirty side, and we peel all the dirty stuff off, and underneath is left a clean setup with clean IABAN that's on the patient still. And it's a safer and way more efficient way to do this, I think. And so we've got a ViewMedi video on that if you want to see that. And I think when you're talking about 2-stage revision, you have to realize this is a team surgery. It's a team sport, and we're not the only ones involved. And we need to really have an ID doc that's really closely involved with us, just like the cancer docs have their oncologists that help, with all the oncologic medication management. I think we need to be dealing with ID docs and having a team approach this. And we've really done that at our place. We've published on that and what it's meant for our patients and for our outcomes. And I think it's helped us all be better. When it comes to knee articulating spacers, there's a lot on the market, metal on poly, cement on cement spacers, either molded or prefab. This is something that I've been passionate about over the years and kind of have put a bunch of work into. But, I started looking at the cost of these things, and you would think that the metal on poly spacers would be the most expensive, and it's not a good use of our resources. But in reality, it's actually the cheapest option for us. These pre-molded or these cement molded spacers are quite expensive. The molds that they used to sell were really expensive, $3,000. That's how the companies can afford to keep making these things. And these prefab spacers that have really low rates of antibiotics in them are really expensive. And so just using a metal femoral component and an all poly tibia is actually the cheapest way to do our knee spacers, obviously compared to just cement on cement handmade, which that's the cheapest, but those really don't work very well. So my evolution, I started just doing these molded spacers back when I started practice, and, they did okay. They kind of ground and popped and patients were doing all right. But then I had this guy in 2016 came in bilateral infections, and he's young. He's 56. He was actually quite athletic guy. And so, I decided I was going to do metal on poly spacers in him and let him walk because I didn't know what else to do. This was him at 6 weeks with his bilateral spacers in. And it really kind of opened my eyes to what patients could do if you did a well done balanced spacer with metal on poly parts compared to these cement on cement, components. Right around that time, Gil Scuderi published a meta-analysis of really all the spacer types on the market and found there was no difference in infection eradication, but the metal on poly spacers really had the least complications and the best interim range of motion. And so for me, that was kind of the time when I just switched altogether and everything became metal on poly. And we've been working on kind of developing an algorithm to make this an easier process to balance, and I'll show you that. We've published this in terms of a technique, and so for the residents or fellows, if you want to have this as a way to do it, we've published that, and then we have a ViewMedi video as well if you want to see how to do it. And another thing we've added in the last several years is putting a patella on. I kind of got tired of watching my spacers and watching the patellas just fragment and melt because we sort of ignored that bone. We took all the parts out and then just left that unresurfaced. And we saw things like that on that top thing. So, I was already putting an all poly tibia, and I decided, why not just put a patella poly in? And I retrospectively looked at our experience with it and found that we had no difference in infection eradication with putting the patella button in, decreased patella fractures and subluxations, and better ability to resurface the patella at stage 2 because the patella was no longer this thin potato chip. It was preserved bone. And so we've published this, and hopefully this will change people's thoughts on that. I think it does make a difference. So, when it comes to putting spacers in, it's all about debridement. We explant the parts, do a really thorough debridement. It should be something you spend a lot of time with. And we debride the canals because I think the canals are common places of contamination. And then we're left with, a nice clean field. And then we balance the knee. So I actually take a CR femur. I put it on the end of the femur to make sure that it kind of fits and have the right size. I size the tibia to figure out what size all poly tibia to open. And then I balance it with that femoral component on there with a mechanical balancer. So I balance my extension gap, figure out how big that gap is, then balance my flexion gap and adjust the balance with augments as you would with any revision. And once I figure out where my augments need to be, posteriorly, distally, laterally, all those kind of things, I then have a component that I need to build. And so I have this spacer maker, which we created, just dowel sizer and then a little space to build augments on the tibia. I drill into an all poly tibia with a fully threaded Steinman pin, cut that off to length, coat antibiotics around it to make a unitized stem, and do that to size, and then just build up the undersurface here with antibiotic cement to make an augment on the undersurface of the tibia to give you the gap that you need to fill based on your balancing. And I put augments on the femoral component, just make them out of cement, create a dowel for the femur, and then I have my final parts that look like this. And so you've got an augmented femur that you've created augments out of cement. You've got your all poly tibia with an integrated stem, and then you got this femoral dowel and a patella. Then we've debrided and cleaned and washed, stripped the drapes. That's our new clean field of that under second drape that we had on, and then our clean parts to put in. Then we mix another batch of wet cement and cement that tibia in place, deliver the femur over the top, put the dowel in, coat the femoral component with cement as well as the distal femur, and then cement our parts on and bring the knee out to extension and put the patella on. And you're left with something that looks like this. It's a well-balanced, augmented revision done with just a metal femoral component and an all poly tibia and integrated stems. And I have some of these running around that are 6 or 7 years out, and the patients are doing well and they have no issues. So they can last and they do not lead to bone loss, like some of these unstable spacers that wiggle around on the bone. If these loosen, you can take them out. You can also treat them just like a standard 2-stage, and 6 weeks later take them out. But we found that patients are liking them, often like them better than their primaries because they're actually balanced, and they move on and just deal with them. If you have to take them out, or when you do go on to explantation, usually just flex the femur up, work on the surfaces a bit and knock it out, and it comes out as a unit because it unitizes itself. And then you take the tibia out without much difficulty. I think with any spacer, you need to be putting in more than one antibiotic. And so that's something that we focus on, is making sure that you're putting on more than one antibiotic in the cement because it helps solution of both. And one thing we learned during COVID is we were historically doing Vanco and Tobra, but Tobra sort of became unavailable due to supply chain issues. And so we had to switch, and we switched to ceftazidime because of its coverage. But there was a question about heat stability. If you look at these stability charts, the heat stability of Tobra and Vanco looks good for cement, but ceftazidime does not. But there was some predicate data showing that there was in vitro and in vivo success with ceftazidime in cement. And so we decided to try it. And we retrospectively looked at our first 120 cases or so compared to tobramycin historically, and found no difference in our infection recurrence rates, both at 90 days and a year with ceftazidime. And then surprisingly, we found that we saved about $69,000 per 100 patients because ceftazidime is dramatically cheaper than Tobra. So it's become now our standard. We use Vanc and ceftazidime. It's also much easier to mix than the Tobra. The Tobra is kind of chunky. The ceftaz mixes in really easily with the cement. For hip spacers, all the same principles apply. I think articulation is key. But I think principles of limb length and offset are often ignored in spacers. And what I've been teaching my fellows is that we need to try to shorten and decrease the offset if possible in our spacers, especially if we use these semi-constrained liners like Prostelac. And that gives the ability for the hip to scar in. And then when you come back, you can bring them back out to length without having to over-lengthen them and hopefully decrease our dislocation rate. And we've looked at that. We're about to publish on that if we keep our spacers the same length or slightly shorter and don't lengthen them, we actually have lower dislocation rates at our stage 2. Well, other thing we've looked at is these thin core spacers. These are now off the market, but if you're using thin core spacers and doing ETO, we found a 25% stem fracture rate when you have an ETO and a thin core spacer. So, we did these pretty routinely and we abandoned them, and then they went off the market. But now we use these more thicker core spacers like the Prostelac that is just a more robust stem that is not likely to break. So I think some people are still out there making spacers by hand, putting like a K wire down. If you think about that, the integrity of that stem is not very much, so be careful. And then I think if you've got big acetabular defects, this is a great paper in JAOS, just highlighting the ability to use screws. We use these kind of constructs quite a bit, where we put screws in like augments to then center the poly where we want, and then we'll actually put the poly in and cement it in, and then drill through the whole construct and put screws through the poly, through the cement, into the bone to anchor. And we have a series of 23 of these we're about to publish, just showing that in really bad defects, we've not had any loosening or failures in these cases. So another way to kind of get around discontinuities and bad defects with spacers. And then obviously there's some severe bone loss cases like this where you could just make proximal femoral replacements and things like that on the back table using the same idea where you let the spacer cure, build it out of cement, and then put it in and actually have successful, spacers with really bad situations. So I think in summary on the spacers, you should be using articulation whenever possible. Got to double drape, I think, and treat the field as dirty, and don't put in just dirty parts for either your spacer or your reimplantation. And I think metal on poly spacers in both the hip and the knee really are helpful, and I think can be quite cost effective. And then there's obviously cases like this when everything hits the fan and you don't know what else to do. And unfortunately in the knee space, we end up doing things like fusion and amputation. And if you look at the outcomes of these, really fusion isn't much better than amputation. And probably the best patient off is the one that gets an amputation, has a prosthetic, and can use it. But if you look at the patients that get amputation, 94% of them have a prosthetic, but only about half use it, and only about half are satisfied with their quality of life. So, these are things that we need to try to be avoiding. And hopefully in the future, we'll have some better options for these patients. Where are we headed in this space? Well, I hope to better places, because obviously we're still struggling. I'm hoping that we're going to come up with some sort of a genetic profile for patients and understand genetic predispositions. We do finally have some data on one of our families, and hopefully this year we'll be publishing some info on potential genetic targets. The BRCA1 and 2 genes were discovered in Utah through our database, and so hoping that we can do something similar in PJI, although I don't think it'll be quite as simple as this, but developing some screening tools I think would be helpful. I think there are coatings on the horizon, as we were talking about in our case conference today. Oncos has the first FDA-approved coating for in an antibacterial coating, and this is actually an biofilm coating that hopefully will make an impact, and I think that would be huge. There are concepts like bacteriophage treatment and therapy, where you can actually culture up phage to be targeted at whatever bug that you have, and then inject the phage in the patient and let that attack the bacteria. There's small case reports and series on this. Nothing really in terms of big data. While the recurrence rates look quite good on patients that are on suppression, there are cases of transaminitis that have developed from this, and so not sure about the complication profile yet on that. And then I think future directions for amputee patients are percutaneous osseointegration, something that I'm kind of passionate about, and hopefully we'll figure this out a bit better and have this as an option for some of our patients. And so I think a better understanding of our risk for our patients is hopeful, and I think on the horizon, and that may help us avoid this problem, which is what we need to be doing when at all possible, is trying to prevent this. I think we do need to avoid, though, buying into the latest magic potion or the latest antibiotic study that shows that if you just give a little bit more antibiotics or you float it in the wound or whatever, just to think that that's going to really solve the problem. I think soft tissue friendly surgery is probably the biggest thing that I could tell you about, and try to just be honest about your technique and try to really be friendly to soft tissues. That's probably more important than anything. We need to be careful with antibiotic utilization. I think it's getting a little bit out of hand in our field. I think we're going to run into some problems with that. And I do think that single stage revisions are going to become the gold standard. And in the next decade, I think that's what we're going to be doing fairly routinely, but still yet to have final data on that. So with that, a lot of stuff that obviously I'm telling you about, and I don't think any of them are really going to change practice for you, but hopefully some food for thought, and hopefully somebody will start to kind of delve into some fun infection projects moving forward. So thanks.
All right. Thanks, Dr. Gilliland. That was a great talk and a lot of really useful information. I think we have a few minutes for questions or comments. See Dr. K's hand. We'll start there.
I'd like your opinions on just two things in terms of quality, some of the quality work that we're doing. So one of the things is, how long do you wait for the prep to dry on alcohol-based preps? Can you use that once you prep it? Can you go right away and drape, or do you have to wait until it dries? Because the package says you should wait.
Yeah,
all the nurses said you should wait, but I don't think there's any real data that suggests waiting makes a difference.
Yeah,
And the second question is nasal decolonization. Do you use it? What do you use? Why do you use it? And do you think it makes any difference?
Yeah, really good questions. The aqueous-based preps, I think that there's probably a couple things at play there. Yes, the packages recommend a drying period of usually 3 minutes. I think it also depends on whether you're putting down an incised-through drape like Ioban. If you're putting any of those down and it's on a wet surface, it doesn't stick. And if you use any of those type of drapes and they don't stick and they start to peel up, they end up peeling off your prep, and actually the rates of infection go up quite a bit. And so actually, if you look at the big systematic reviews on incised through drapes, there's no difference in infection rate using those products, and probably some because some of those just peel up, especially if you don't wait for your prep to dry. So it really depends a lot on kind of how you're doing your overall prep. I think most of the time, you can prep, continue draping, and by the time you get to making incision, things have dried and it's probably still effective. The nurses will get on your case about, you got to wait for 3 minutes, or you got to stare at the clock. I get it. It's quite annoying, but I think it is recommended to have it dry. As far as the nasal decolonization is concerned, so that's a whole another talk in and of itself, and didn't include it here because there's a lot of thoughts in that space. What we do is we still screen patients, and I think a lot of people have fallen away from screening. They just said, look, why screen? Let's just do routine decolonization of everybody. But the reality is, I think with screening, another thing pops up. You can find the patients that have MRSA, and then you can target your antibiotic regimen preoperatively to include vancomycin and ANSEF. And so we screen everybody. We also decolonize everybody. So everybody gets an iodine-based nasal decolonization in the preoperative area, but everybody gets screened as well. And those that pop up with MRSA get vancomycin in addition to ANSEF. The one challenge there is it needs to be in addition to. You got to tell your anesthesiologist, no, I know they popped up positive MRSA. We got to give them ANSEF as well. It's not the vanco in isolation. And that's something that I think can throw a wrench into things. But we do decolonize everybody and screen everybody. May not be the most cost-effective way, but I think it does eliminate some of those MRSA positive patients you might miss.
Mm-hmm. Dr. Westrak.
Thank you so much. I'm a tumor surgeon, so our infection rate is slightly higher than yours. So it's something we deal with a lot. But I was wondering if you could tell us a little bit about what you mean exactly by soft tissue handling and what are some skills you've learned along the way to be kind to the soft tissues.
Yeah, I mean, I think it's very hard to quantify. It's certainly hard to study, right? And so I find it really interesting when there are these single surgeon series that get published and they say, oh, my infection rate is 0.01% or whatever. It's like, great. How can we quantify what you're doing that's better than others? But I think it really does boil down to soft tissue management. I think that the basics, like not pinching the skin and grabbing the skin with your forceps, right? Some simple things like that, trying not to kill the skin that way. I use some, like in anterior hip replacement, there's sometimes a lot of times the broaches and things will beat up the soft tissue. I use a Kevlar-based skin protector that goes in deep to so I make skin incision. I'm very cautious about not undermining the skin. And that's something that gets done a lot where people just sort of strip all the fat all the way down to the fascia and undermine some of the blood flow of the skin, as well as create dead spaces. And dead spaces, I think, are our enemies. And so I'm super cautious to get down to fascia, get to the muscles, develop my planes under the muscles, and then actually put in a protector that stays deep to the muscle and doesn't move and really sort of protects all the superficial tissues, which I think those are sort of the imperative tissues that we really need to protect. Because once those start to get damaged, and then you start to get breakdown of the skin interface that you're trying to get to heal, then you get bacterial invasion, and then boom, like you set up the cascade that you can't recover from. And so I think it's just really imperative that the residents think long and hard about when you're doing a case to just be nice to the soft tissues and be cautious with them, because any sort of damage to them just sets up the environment that can lead to trouble.
Dr. Claudio Diaz sends his regards from Chile.
Yeah.
And
I wish I was.
I think he is ready to unmute. Dr. Diaz, are you there?
Yes, I'm here. Thank you. So, Dr. Gilligan, thank you so much for all the hard work you have done. We have learned a lot from you, and unfortunately, I wasn't able to be there. But I'm wondering, because it wasn't covered on your presentation, what are your thoughts regarding the intraosseous regional antibiotics, which is what we call an award-winning concept? It seems to work really well, but unfortunately, it hasn't become yet the standard of care. What are your thoughts on those strategies?
Yeah, I mean, thanks, Claudio, for the question. It's a great question. I think the IO, it's been IO vanc has been what we've been looking at most in our field. Has been quite stimulating in terms of a potential, concept. I mean, the concept is that you're putting in this IO vancomycin and it goes in through collateral blood supply after you've put up a tourniquet in a knee case. And so through collateralization, you get all this really high concentration of vancomycin within the tissues. And probably the difference there, Claudio, with what I was talking about with powdered vanco, why the IO vanc I think has been really successful is because you're not just throwing powdered vanc into a wound, which has some of its own toxic effects. You're actually putting the vanco into the bloodstream and into the supply, and it actually just sort of infiltrates the bone and soft tissues, gets into the tissues, and doesn't just sit on the surface. I do think it works quite well. It's a little onerous to do if you've tried it in your own practice. Like, I think doing it in every single case, I think could be one, not super cost effective because the needles are a little bit expensive. But I think in terms of aseptic revisions, DAIR cases, those are cases where we're using it routinely now. I think it's a good way to get a high concentration of antibiotics to the local soft tissues and certainly has some good data behind it. So yeah, we are using it in revision cases and in DAIR cases.
Thank you so much.
Mm-hmm.
All right. Thank you. I think we have some more questions, but maybe we could take them offline, but we should probably wrap up in the interest of time. But thank you so much for visiting. This was a great talk. And then just to commemorate, we have a plaque for you as well.
Thank you guys for having me.